There are three main points that I would like to make in the time available to me. Firstly, HIV and TB co-infection in South Africa and the high incidence of that, and the necessity to move towards community-based TB treatment. That's addressing the isolation of MDR patients. Secondly, regional cross-border TB control for migrant workers, including the treatment of MDR-TB. And three, strengthening regional laboratory capacity for the diagnosis of DR-TB. You will see in virtually all of these 3 points, we are pointing to the necessity for regional cooperation. Co-infection in South Africa and community-based treatment. As you are aware, South Africa is one of several of the high-burden TB countries in the world. Unfortunately, we are also a country with a high HIV prevalence, meaning that our TB-HIV co-infection rates are very high. In 2007, 354,000 TB patients were started on treatment, and that is an incidence of about 948 per 100,000 people. In 2007, 7,191 MDR-TB patients were started on treatment and 563 XDR patients. In 2008, slightly lower figures, 5,842 started on treatment on MDR and 482 on XDR. But as we all know, these statistics are subject to the ability of our healthcare workers to timeously diagnose, and so we would have to look at the reliability of this. The development and treatment of and subsequent transmission of drug-resistant strains of TB is very worrying in our country. But it has highlighted the need for us to focus on strengthening our national TB program and simultaneously addressing DR-TB and HIV. In 2006, we had reports of an XDR-TB outbreak in one of our provinces. This is a province with a high incidence of HIV as well. In responding to that outbreak, we sought technical assistance from the WHO and other partners to support us in understanding the outbreak and in designing appropriate interventions, which included, firstly, revising our guidelines for the management of drug-resistant TB, which has now been done, the training of healthcare workers specifically on treatment protocols for MDR and XDR, fast-tracking second-line drugs that were not registered or available in our country at that time for registration and procurement purposes, increasing access to laboratory culture and drug susceptibility testing, working on models for rapid diagnostic procedures, accrediting MDR-TB hospitals to provide ARV treatment to co-infected patients, and developing infection control guidelines. But let me say that we are in an ongoing process of addressing infection control measures, and this continues to be a significant challenge for us. Let us bear in mind the high poverty levels that we have in our country. Importantly, a drug resistance survey will be conducted in the second half of this year, and then every 3 years thereafter with the assistance of the WHO. Now, looking at the isolation of patients, whilst the decision was taken by South Africa and many other countries to hospitalize drug-resistant patients until they are non-infectious, in South Africa we are committed to piloting projects that will explore the use of community-based treatment of drug-resistant TB in line with human rights protections based on what the WHO is now recommending in its revised DR-TB guidelines. I am hopeful that the South African Health Department will review pilot projects and fully develop a policy proposal on community-based treatment of drug-resistant TB that fully considers the human and health rights of patients and the communities that they come from. And this, we are anticipating that this will happen within a month. In terms of cross-border TB control, This is a very important issue to us. It concerns us that employers, particularly mining companies, who employ large numbers of people from both within our country and outside our country, they are responsible often for the conditions that give rise to TB on the one hand. And the difficulty is that the countries and officials responsible for diagnosing and treating such cases, on the other hand, are two separate bodies, and they are often not meeting together with a sense of the urgency and collective responsibility required. I say this because the TB incidence rate in miners has been increasing exponentially with HIV every year. And the gold mining industry in particular has probably the highest incidence of TB in the world. TB in gold mines is also linked to the poor control of crystalline silica dust levels. And in 2008, the South African Presidential Mine Health and Safety Audit showed the very high levels of crystalline silica dust. And therefore, with the turndown in the economy and the mass retrenchment of workers, including mine workers, we are anticipating that without proper referral systems, that we could be both exporting and importing greater problems into our countries. I'm therefore asking you for your help to make diagnosis, treatment, and referral in particular a reality. Let us develop a shared cross-border TB control problem. Regional health cards and health passports for migrant workers are just the first step. And yes, I'm appealing to the private sector too, to please pay greater attention to the issue of MDR-TB and HIV. Let me say incidentally that in our private sector, they do, particularly in our mines, they do treat HIV and TB people, but we need that to be integrated with our public sector programs. The third and final issue is that of laboratory capacity. I cannot stress the sheer urgency for donors, governments, and technical experts to explore regional means to expeditiously and smartly diagnose DR-TB and implement treatment regimens. Where a patient with TB is also living with HIV, then that aspect of treatment must also be addressed and prioritized. Given the crisis we face, there is a regional imperative to ensure that tools are available for the diagnosis and treatment of TB and DR-TB in all countries, especially ones classified as high burden. In South Africa, we often do the diagnosis from a laboratory point of view for other countries, but we really need to look at shoring up our regional health laboratory capacities. Access to health services is a constitutional right in South Africa, and it is free. And we are committed to ensuring that this right is progressively realized, despite the enormous financial constraints that it imposes on us. For this reason, we must improve on our TB cure rate, and I thank you.